Okay, good afternoon. Thank you very much for joining us in today's symposium. So the talk is entitled Peculiarities in the Treatment of Lipid Disorders Among Filipinos and Asians. Does one size fit all? So these are my disclosures. And for this session, we'll try to look at the prevalence of dyslipidemia and lipid patterns in the Asian population. And we'll look at issues in lipid management, specifically based on the 2018 ACC and AHA recommendation, as well as the 2019 ESC recommendation, particularly on risk scoring, efficacy of treatment, and concerns on safety. 2 years ago, I was able to be part of a review article published in the International Journal of General Medicine, looking at the applicability of dyslipidemia guidelines in Asia as well as the Middle East. We particularly look at dyslipidemia prevalence and groups of increased risk in Asia and the Middle East. If you look at data from the Philippines, especially looking at the lipid patterns, you will see that the Philippines is characterized by low HDL cholesterol with levels of 71.3%. And this is highly characteristic of Filipinos compared to, for example, China, Taiwan, Indonesia, and Thailand. A low HDL cholesterol of about 71.3%. This dyslipidemia prevalence has been noted since 2003 and up to the most recent FNRI survey, okay, in 2013. So unfortunately, the 2015 and the 2018 survey did not show or did not look at lipid patterns. So as you can see in this 2013 dyslipidemia prevalence, the prevalence of low HDL, defined as HDL of less than 40 milligrams per deciliter, is as much as 71.3%. So again, very characteristic in the Asian and Filipino population. Similarly, when they looked at 4 ethnic groups in Indonesia, also looking at the prevalence of dyslipidemia, we will see the characteristic dyslipidemia patterns. What is important in these 4 racial or ethnic groups in Indonesia was the high level of LDL cholesterol, more than 160 milligrams per deciliter, among women in Minangkabau. Okay, but what's also very important is the prevalence of likewise low HDL, in this case defined as less than 35 milligrams per deciliter in Sundanese men in Indonesia, just like the pattern that we saw in the Philippines. And similarly, in a national survey on the risk factors of non-communicable diseases in Vietnam in 2015, we also see the high prevalence of low HDL cholesterol in both men and women, as much as 63.7 to 70.4% of less than 40 milligrams per deciliter of HDL in Vietnamese men, and as much as 68.7 to 75.2% of low HDL defined as less than 50 milligrams per deciliter in Vietnamese women. And when you compare that to other Asian population, no, Japanese, okay, Taiwan, Korea, and China, again, the characteristic low HDL pattern is primarily seen among Filipinos, among Indonesian, and to some degree, patients from Thailand. So there is a characteristic difference with regards to lipid patterns in Asia, no? That includes, of course, Southeast Asia. It's a very nice study looking at the racial and ethnic differences in dyslipidemia patients, and this study was done in the United States. They tried to identify racial and ethnic differences in dyslipidemia among minorities, including Asian Americans. So Asian Americans, Mexican Americans, and Blacks compared to non-Hispanic whites. And the Asian Americans were divided into Asian Indians, Chinese, Filipino, Japanese, Korean, or Vietnamese. When they politically look at the prevalence odd ratios for racial or ethnic differences in dyslipidemia subjects, they look at the lipid patterns, those with high LDL, those with low HDL, and those with high triglyceride. Okay, so I marked it this way. So those with high LDL, low HDL, and high triglyceride. So if you look at those particular patterns, you will see that Filipino women in particular Aside from Filipino women, Asian Indians, especially men, and Vietnamese women have the highest risk for possessing all three dyslipidemia subtypes versus your non-Hispanic whites, meaning those with high LDL and those with low HDL and those with high triglyceride. And there are variations in cardiovascular burden among racial ethnic subgroups in the US based on these studies. And they've noted that Asians and Mexican Americans appear to possess the high triglyceride and low HDL pattern, which has been characterized as atherogenic and associated with metabolic syndrome. Again, this is particularly true among Filipinos as well. Asian Indians and Filipinos have consistently been shown to have increased risk for coronary heart disease with high mortality rates than other racial or ethnic groups in the United States. So again, showing to us the higher risk now among Filipinos even in the United States. So this is a very nice study looking at the high prevalence, on the other hand, of low HDL cholesterol in the Philippines compared to the US population. So this is looking at population differences in association with diet and BMI. What they did was compare adult Filipino women in the Philippines, in Cebu, to match US women in the United States via the National Health and Nutrition Examination Survey, and they try to assess the relationship between lipid components, BMI, and dietary variables in the two populations. So again, they were compared those patients in Cebu and those patients or women in the United States based on data from the NHES, and they looked at particular abnormal lipid phenotypes. So those with low HDL and normal triglyceridemic, meaning HDL of less than 35 with triglyceride of less than 200. Those patients with hyperlipidemia, meaning with HDL of less than 35 and with triglyceride of more than 200, or those with severe dyslipidemia, meaning those with cholesterol of more than 300 and more than 500 of triglyceride. And then again, compare those women in Cebu and in the United States. And if you look at the outcomes at the bottom, you will see that there is 13.7 times greater number of low HDL and low triglyceride in Cebu versus that in the United States. There's 7.3 times greater, okay, hyperlipidemia, meaning HDL that is low and triglyceride that is elevated in Cebu versus that in the United States among women. And those with severe dyslipidemia is 1.81 times greater, again, in the Philippines versus that in the United States. And then when they looked at multiple logistic regression, predicting presence of the isolated low HDL phenotype stratified by age, they noted that BMI, total caloric intake, and age did not predict the phenotype of isolated low HDL phenotype. And that is probably because aside from those possible reasons, we saw in an article published or done by Dr. Rodici and his group looking at polymorphism among Filipinos with cardiovascular risk factor, they noted that cholesterol ester transfer protein polymerism exists in Filipinos, particularly the B1 polymorphism, which is more commonly associated with low HDL cholesterol. So there could be a genetic reason why Filipinos have low HDL cholesterol. And this is again is a very important differentiation when we looked at several recommendations, particularly in the Asian population, with regards to use of the 2018 ACC and the 2019 ESC guidelines in the management of dyslipidemia. We're well aware of the ACC and AHA guidelines. So these are basically the summary slide on the primary and secondary ASCVD prevention. So there are recommendations for both. For primary prevention, very important that there are recommendations, particularly for those 40 to 75 years old. Okay, the data for those patients less than 40 is not as robust, so that there are what we call ASCVD risk enhancers, and very important for those risk enhancers is ethnicity. And we'll be talking about in detail the value of ethnicity in deciding therapy in the ACC-AHA recommendation in 2018. Okay, so this is the overview of the primary and secondary ACVT prevention recommendations. You basically know that in the recommendation, that either high intensity or moderate intensity statin therapy are recommended for those patients, even for primary and secondary ACVD prevention. And in most cases, if they were not our target, ezetimibe may be a reasonable add-on therapy or even a PCSK9 inhibitor, okay, for some patients. So we also know that based on the recommendation, when we talk about high-intensity statin, these are therapies that are expected to lower LDL cholesterol at baseline to as much as a 50% reduction. And this, of course, includes your Ator at 40 to 80 milligrams, as well as your rosuvastatin at 20 to 40 milligrams. Your moderate-intensity statins, on the other hand, are expected to lower your baseline LDL cholesterol to as much as 30 to 49%, and your low-intensity statin, like simvastatin 10 milligrams, to less than 30% reduction. Okay, in the ESC recommendations, basically the recommendations are the same with regards to statin therapy. When we start very high intensity, again, very high risk patients, we recommend a high intensity statin. For high risk patients, a high or a moderate intensity statin, and so forth. So in the 2019 ESC recommendations, you have there that when you start a patient on a moderate intensity statin, there's an average 30% reduction in the LDL. With a high intensity statin, as much as a 50% reduction. With a high intensity statin plus ezetimibe, you see a 65% reduction. Okay, so those are the expected reduction of LDL with the different intensities of statin treatment. We now go to the issues with regards to this recommendation. It's very clear in the 2018 recommendation that ethnicity is an important issue with regards to starting statin or treating dyslipidemia in general. As you can see here, the ethnicity issues, especially among Asian Americans, in evaluation risk decisions of ACVD risk. One of the issues is that in South Asian and East Asian ACVD risk, it varies by country of origin, whereby South Asians have higher ACVD risk. So the Philippines is actually included not in South Asia, not in East Asia, but in the Southeast Asian region. So just a review of your geography, you will see that when we talk about South Asians, these are people coming from Bangladesh, from India, from Nepal, Pakistan, and Sri Lanka. And again, the 2018 AHAAC recommendation tells us that there are higher risks for these patients coming from the South Asian regions versus East Asians. So when we talk about East Asians, we're talking about Japan, Korea, and China. So comparing South Asians and East Asians, you see that East Asian population have lower risk compared to South Asians. But what about us, the Philippines, or the rest of the Southeast Asian region? Unfortunately, the data is lacking, so that we don't have those particular recommendations in the ACC recommendation. This is data looking at the proportional mortality rates for cardiovascular and cerebrovascular disease in the Asian American subgroup. Again, this was published in the Circulation, highlighting the risk for all cardiovascular disease as well as cardiovascular disease in the different Asian population. So if you look at those proportional mortality ratio between men and women, so if you look at the higher rates, so ano ba yung higher rates? Light blue, and these are Asian Indians. And next to that, unfortunately, are those patients in purple, and these are Filipinos. So unfortunately, the results of this study showed that South Asians have been found to have a higher proportional mortality rate from ischemic heart disease compared with other Asian ethnic groups and whites or the non-Hispanic whites. So again, aside from South Asians, we have Filipinos as those with proportionately higher mortality rates due to cardiovascular and cerebrovascular disease in this particular study. So other ethnicity issues, you have HDL cholesterol that is lower, as we've said, and higher prevalence of LDL cholesterol among Asian Indians, Filipinos, Japanese, and Vietnamese versus whites. You also have a high prevalence of high triglycerides that has been seen in all Asian American subgroups. So again, there are peculiarities in lipid management among Asian population. Okay. If we go about metabolic syndrome, the Asian type 2 diabetes also has a particular phenotype. So we have high prevalence of young onset diabetes, we have metabolic syndrome and beta cell dysfunction, and the higher degree of insulin resistance. The Asian diabetic is also diagnosed before age 40, and it is associated with a higher cardiovascular disease risk, which is attributed to the longer duration of the disease. We have lesser lean muscle mass, but higher visceral fat mass and lower circulating adiponectin, which is actually a good adipokine. And lastly, East Asia populations have reduced insulin response to the metabolic stress like obesity. So all of this again contribute to higher cardiovascular risk. Other issues in the recommendation is risk scoring. Unfortunately, there are no separate pooled cohort equation available. So that if we use the American pooled cohort equation, it will actually underestimate risk among South Asians and will overestimate risk in East Asian population. Again, for Southeast Asian, we don't know. But this is just one illustration, one case showing the differences in risk stratification. So we have here a 44-year-old male bank employee, a smoker, high cholesterol of 238, non-diabetic but pre-diabetic, the HDL of 48 and LDL of 149. If we use the ASCVD risk calculator, okay, this is the risk calculator. If you compute for this risk, you see that the risk is 8.4%. So that's a relatively high risk, okay? Moderate to high risk already. But if you use the thigh, no, the Thailand actually, the thigh actually have a CV risk calculator. If you use the thigh risk, it would compute the 10-year risk to be at 4.8%, which is classified as a low risk. So that shows you that when you use a particular risk calculator that is not standardized for the country, you will have a different value for risk stratification. If you, for example, use the score chart, this is the ESC score chart. Again, looking at risk, so the score chart has particular calculations for low-risk regions of Europe or high-risk regions in Europe. And if we apply the same risk stratification for our case, you will see that the risks are different, no? For this male patient. And the healthy heart score will also be different. Okay, so that's why it is very important that we do our own risk calculation, okay, or pooled risk calculation. In the Philippines, unfortunately, we don't have this risk calculator. The decision to start a statin is based on risk counting only. So in the 2015 and even in the 2020 new guidelines, the decision is to start therapy for lipids or anti-lipids is for the number of risk factors. So for example, if patient is diabetic, then that patient should be on a statin. If not, but 45 years old and above with 2 risk factor, if yes, screen for lipid profile. If the LDL is 130, then that patient should be started on a statin. So that the decision for statin therapy is not through a calculator, but just for risk counting. Okay? So other issues with regards to ethnicity is intensity of statin use or efficacy. As you can see in the 2018 recommendation, Japanese patients may be sensitive to statin dosing, so that primary prevention trial or reduction in CV events with low intensity doses of pravastatin has been noted compared to placebo. On the other hand, secondary prevention trial, participants with CAD benefited also from a moderate intensity doses of pitavastatin. Okay, so again, most recommendations will tell us that you start either on a moderate for primary prevention and a high intensity statin for secondary prevention, but it doesn't look the same with regards to these two recommendations from the ACC. So with regards to efficacy, we have to remember that almost all evidence originated in Western countries based primarily on data from white subjects. There is a possibility that the response to statin therapy differs among different regions or in different ethnicities, especially among Asians. So this is a list of clinical trials of statin therapy in Asian population with regards to lipid-lowering efficacy. So these are the trials, both open label and randomized trial And these are the statin that were used, no, in different countries, China, Japan, and you look at the mean LDL reduction, so that even, for example, with just 10 to 20 milligrams of atorvastatin, there was a 48% reduction, which actually don't expect, no? Because 48%, even for a 10 atorvastatin dose, is quite a significant drop in the LDL. And this holds true for most of the other statins. For Simva, for Rosu, again, you see a robust reduction in LDL cholesterol, even for the lower doses of statin. So again, these are clinical trials, statin therapy, looking now at outcomes that even for 10 to 20 milligrams of pravastatin, there was significant drop in coronary heart disease events, no, with the use of the lower doses of pravastatin and even simvastatin among the Asian population. And this is why the recommended dose ranges for selected statins in Japan compared to United States are different. So as you can see, the recommended statin dose for atorvastatin, for example, in the United States is between 10 to 80, and that is just half in Japan. This holds true with fluvastatin, pravastatin, rosuvastatin, and even simvastatin. And in the Philippines, if you look at efficacy data also, there was a study conducted several years back. This was published in the PGIM, whereby they look at the efficacy, particularly of atorvastatin among Filipinos. So this is comparing 10 and 20 milligrams of atorvastatin after 4 weeks of treatment. And you see that even for the 10 and 20 milligrams of atorvastatin, it was very potent with regards to reduction, no, of LDL, no, 34.7% or 43.7%, okay, reduction, no, in LDL cholesterol from baseline. And this holds true with the different doses of atorvastatin at 10, 20, 40, and 80 milligrams. As you can see, with 80 milligrams, there's more than 60 or 65% reduction from baseline. With the 40 milligrams, a 60% reduction. With 20 milligrams, as much as 55% reduction, while 20 milligrams is just moderate intensity atorvastatin. And comparison of the efficacy and tolerability of simvastatin and atorvastatin also showed that the percent reduction in LDL, okay, with the 10 or the 20 milligrams of simvastatin is as much as 35 to 42%. Even with the lower doses, you see a significant drop in LDL. So that's for efficacy. How about for statin safety? There are issues on safety. As you can see here, statins, especially lower doses, are well tolerated by Asians. However, pharmacogenetics is showing differences in the pharmacokinetic and the pharmacodynamic response to statin treatment. So this is a study looking at the major adverse drug events during the JLIT extension study among patients given simvastatin, 5 to 10 milligrams after 6 and 5 years. So as you can see, there's a relatively higher rate of adverse events, even for the low doses of simvastatin. So issues of safety, if you look at again the 2018 guidelines, ACC, higher rosuvastatin plasma levels are seen in Japanese, Chinese, Malay, and Asian Indians versus whites. So that the FDA recommends lower starting doses of rosuvastatin, that's 5 milligrams in Asians versus 10 milligrams in whites, and caution urged as dose is uptitrated. So these are issues on safety. And this is a study looking at concentration or exposure of particularly rosuvastatin at 20 milligrams single dose in Caucasians versus pooled Asian cohorts. So Chinese, Filipino, Asian Indians, Korean, Vietnamese, and Japanese. They looked at the concentration, the area under the curve, the Cmax, the half-life, as well as the Tmax of rosuvastatin compared to Asians, compared to Caucasians. They have noted that plasma exposure was homogeneous among 5 of the Asian subgroup except Asian Indians. So that rosuvastatin, area under the curve, and the Cmax were significantly higher among Asians by about 1.7 times compared to Caucasians. And body weight differences contributed to only a less than 10% of the pharmacokinetic differences. So there are really differences in exposure as well as concentration. in a study looking at the rosuvastatin area under the curve and Cmax, looking at polymorphism and genotype by ethnic group, they also noted a difference. That rosuvastatin exposure was higher in subjects carrying the ABCG2421A allele compared with that who are non-carriers, suggesting that polymorphism contributes to the variability in rosuvastatin exposure. So there are pharmacogenetic reasons for the differences in safety and efficacy of statins. This is also rosuvastatin pharmacokinetics and pharmacogenetics in white and Asian subjects residing in the same environment. So if you look at whites, looking again at plasma concentration in this particular graph, you'll see this is the plasma concentration of rosuvastatin after initial treatment. So that among whites, the plasma concentration is not as much. But if you look at other ethnicity, Chinese, Asian, Indians, and Malay, looking at A1 area under the curve and Cmax, they are considerably elevated. So that's why, again, ethnicity is important with regards to not just efficacy, but safety of the drug. So in conclusion, hopefully I was able to show you that this lipidemia is highly prevalent in the region, mainly characterized by low levels of HDL and high levels of LDL cholesterol. It is important for clinicians to review race, ethnic features, since this can influence ASCVD risk estimation as well as eventual choice of statin or intensity of treatment. A locally validated CV risk calculator is valuable so as not to underestimate or overestimate ASCVD risk when using risk calculators, especially derived from pooled data from a different patient cohort. And variations in the pharmacodynamic and pharmacokinetic studies of statins can partly be related to genetically based differences in the metabolism of statins at the level of hepatic enzymes and even drug transporters. With that, thank you very much and be safe, everyone.